Good morning, everyone. Welcome to the 2023 Simplifiance webinar. My name is Gina Thorne, and I'm the Chief Marketing Officer for Simplifiance. Today's topic is clinical documentation compliance, how meeting the standards can maximize your revenue. For those of you that are not familiar with Simplifiance, we're a mission-driven team of behavioral healthcare compliance professionals who simplify the complex nature of accreditation and licensing. Our value-based compliance approach includes consulting services and software to simplify solutions to the unique challenges in mental health and substance abuse compliance. If you're interested in a demo or would like to learn more about our services, we invite you to visit us at simplifiance.com. We'd like to give a special thank you to Alan Goodstadt, CEO for Behavioral Healthcare Advisors, for co-presenting today with Parker. If you're interested in learning more about Behavioral Healthcare Advisors, we invite you to visit behavioralhealthcareadvisors.com. Just a few housekeeping rules before we get started. There is going to be a follow-up online evaluation sent at the end of the webinar. Please be sure to complete the online evaluation form and let us know what your feedback is. If you're interested in receiving a certificate of completion, please reach out to Alyssa Martinez. These webinars are not currently approved for CEUs, but if you are looking for a certificate of attendance or a certificate of completion, we can provide one for you. This webinar is being recorded, and if you are interested in accessing it later, please visit our website at simplifiance.com, or you can visit the Simplifiance YouTube channel and watch it there. I'd like to go ahead and introduce our two speakers. Parker Smith is our CEO of Simplifiance. He has a passion for value-based compliance, is driven by his commitment to living a life in service of others and creating solutions to the complex behavioral health challenges our communities face. Alan Goodstadt is the CEO for Behavioral Healthcare Advisors. He serves as the founder and senior advisor. He's had over 30 years of proven track record of providing compliance and corporate health growth management services to small and mid-sized organizations, startups, and pre-exit organizations. Please join me in welcoming Parker and Alan. I'm going to turn it over to Parker today.
Thanks, Gina and Alan, for joining. Looking forward to sharing and educating about clinical documentation compliance and the opportunities that exist from a payer reimbursement standpoint as we move through the presentation. So as Gina mentioned, I am the CEO and founder of Simplifiance. I brought this organization to life with the desire to improve the standard of safety and quality in the behavioral healthcare industry. I've been in behavioral healthcare for 10 years, initially as a counselor. I'm a certified addiction specialist in the state of Colorado. Quickly moved into administration and operations, where my background started to develop in compliance, quality improvement, so on and so forth. So really excited to be here with you today. I'm going to share initially a lot around the basics of clinical documentation compliance from a licensing and accreditation lens. We're going to go over some basic concepts, and then Alan's going to get granular on the opportunities from a payer reimbursement perspective. So the objectives that we're looking to accomplish today is first and foremost to define leadership's role in documentation and compliance, to outline general expectations for clinical documentation from a licensing and accreditation standpoint, discuss acceptable practices for assessment, treatment planning, progress notes, reviews, and discharge/aftercare plans, to understand the documentation and collaboration practices with payer partners during the contracting process and through the provision of care, and understand how utilization review contributes to overall partnership of payers and increasing revenue through various contracting partner opportunities. So those of you that know me know that leadership is what I'm more passionate about than anything else. And one of the standards that I mined from the Joint Commission really speaks to what I subscribe to as an individual and as a professional in our industry. The Leadership 010301 standard reads, governance is ultimately accountable for the safety and quality of care, treatment, and services. and that leaders provide for the coordination of care, treatment, and services among the organization's different programs and services. Leadership is ultimately accountable for outcomes, including the clinical documentation. So the responsibility falls all the way up to the top, the totem pole, and falls down through the rest of the organization from that level. CARF, I think, also has a lovely definition in their standards, and it's a bit paraphrased here, but standard number 2 is a person-centered philosophy is demonstrated by leadership and guides the service delivery. So today we'll talk about how this rolls up into clinical documentation. So one of the concepts that I really enjoy that we've kind of discussed through our various experiences with regulatory authorities is reviewing clinical documentation through the lens of understanding the patient's narrative, not only from their historical background, childhood experiences, and history of use and mental status, but really the episode of treatment and kind of the story that's told through documentation. First and foremost, if there's no documentation, there's no story. And really a concept that was presented to me in a unique forum was that not only is a lack of documentation stealing from the company, but most importantly, it's stealing from the client. And without proper, well thought out, well documented clinical notes and treatment plans, a disservice has really been done to the individual receiving care, because that treatment plan, that clinical documentation, the historical assessments are going to play an integral part in the aftercare plan and an important resource for future providers to be able to use in order to take that person-centered approach to care. So in the clinical documentation, multiple stories are told. First and foremost, the client's behavioral and general healthcare needs. Regulatory authorities are not only looking for the history of drug use and the mental health challenges, but also physical health. Pain screening is a huge indicator for substance abuse. Dental, educational, vocational, these are all important contributing factors to the overall health of the individual. The narrative that's also told through clinical documentation is the provider's competency. A lack of notes, a lack of attention to detail and important information in the documentation really speaks to a challenge area from a clinical or medical perspective. And the overwhelming message or narrative of a full suite EMR and the documentation that exists within it is the organization's overall commitment to quality, which really speaks to my initial point around leadership being ultimately accountable. A lack of quality documentation, that responsibility falls on leadership. So we're going to review some of the baseline expectations from a regulatory standpoint of clinical documentation. And what we're going to cover today is screening and assessment, planning, such as treatment planning, the delivery of services, and how those are documented, the monitor and review of documentation, information, and data as it relates to the care, and transfer and or discharge to another level of care or the next chapter in the individual's life. Starting with assessment and screening, all required assessment data is collected with an early emphasis of risk of harm. This is some low-hanging fruit to meet the clinical documentation requirements, and it's a huge point of emphasis. So typically we see the Columbia Suicide Severity Rating Scale as an assessment tool for harm to self or others, a very important part of the process, and unfortunately a gap that we see in a lot of clinical documentation that exists out there. So first and foremost, we want to screen for suicidality and the risk of harm. And that should be done, in the very first set of conversations that are happening with the individual, including determining if they meet the criteria for admission. So the next natural step after there's been a confirmation of appropriateness for the levels of care and program services that are being offered is the pre-admission screen. Many of the required assessment standards can be collected through this process. And then through the admission and preliminary planning process, the rest of those pieces of information can be collected and should be revised and reassessed over the course of treatment. So admissions typically in scope look like a biopsychosocial, which is a very exhaustive but important assessment tool for understanding the whole picture and narrative of the individual's experience leading up to that treatment episode, identifying the chief complaint, creating the master problem list, and then working through the health history screen to identify any other indicators of health needs, and then collecting previous treatment history. So this is a gap that we see fairly commonly in the marketplace. Trying to make a best faith effort to collect previous medical and clinical documentation really should inform modalities and approaches to clinical care, while understanding what may or may not have been strength-based or valuable or supportive of the individual in the past. So we want to make sure that we're collecting and screening all of the different assessment data that's going to inform how the care gets delivered. So planning is really a huge point of emphasis from the regulatory authorities. If you don't have a plan, then what are you really doing? We've gotten some pushback from clinical staff throughout the years about, every treatment episode looks different. And so every plan should look different. And absolutely that's the case. But there are a certain baseline set of standards for treatment planning and reviews that we want to make sure to hit home on today. So referencing the Care Treatment and Services chapter in the Joint Commission Standard 030103 EP1 is that a plan is developed that reflects the assessed needs, strengths, preferences, and goals of the individual served. So a person-centered approach to treatment planning really leans into the assessment data, the individual strengths, what their preferences are, and the goals that they identify in their own words. Objectives are sufficiently specific to assess the progress of the individual and are expressed in terms that provide indices of progress. And as we dive a little bit deeper into the use of data and measurable information as it relates to objectives and goals in the treatment plans, we'll get a little bit more granular and kind of expand on what that means. Related to planning, also you need to address more than just what's going to occur in the treatment episode and shall include, in quotations, factors that support the transition to community integration and the criteria and process for the individual's expected successful transfer and or discharge. I think a lot of organizations have good intentions and speak well to the notion that aftercare planning starts on day one, or discharge planning starts on day one. Very few organizations do we see executing well. We love to see, and so do the regulators, a discharge or aftercare plan actually being populated in the EHR within that first few days, because realistically, you don't know when the discharge or the transfer could occur. There are multiple different factors, including payer source, including willingness to participate, the stages of change that the individual's in and how that fluctuates over time. So constantly having a prepared aftercare plan that's being addressed during treatment plan reviews and throughout the individual sessions and group sessions is really going to set that person up for long-term success, which is at the end of the day what we're really trying to do. And then planning also includes a standardized tool or instrument. So we'll dive a little deeper into what that looks like and what outcomes tracking looks like from a regulatory standpoint. So the delivery of care addresses goals and objectives from the plan. Every progress note, whether it be group or individual or medication management or otherwise, needs to be tied back to that treatment plan. And a lot of EHRs have built in that functionality to be able to click down and select the exact goal and objective and describing the intervention in the progress note, how that is being tied back. And ultimately, if deliveries of services are not related to the treatment plan, then you're falling outside the scope of a person-centered approach to care. And like I had said, groups, individual, and ancillary services should all roll back up into the treatment plan goals and objectives. Each session is documented that indicates the progress made towards the goals and objectives. And in as many cases as reasonable, tying numeric and metrics back to the indices of progress to clearly demonstrate what growth and what progress looks like as it relates to the individual in the ways that they've described their goals and objectives. Monitoring and reviewing, I think, is another challenge area that we see across the provider market. A lot of times good treatment plans are developed, good progress notes are written that tie back to that treatment plan, but the monitor and the review of the treatment plan over time can easily fall by the wayside. So to cite another EP within the Care Treatment and Services section of the Joint Commission's Behavioral Health Manual, the organization uses a standardized tool or instrument to monitor progress relative to goals. We see a lot of different outcomes management and tracking technology companies coming onto the scene and adding a lot of value. We worked with a number of those organizations. We'd be happy to provide some referrals if you're not using some sort of outcomes tracking partner. We would advise that you do entertain adding one of those vendors to really start to look at the data and look at the information that's coming out of the care, treatment, and services that are being provided. The Joint Commission also provides a list of 70 plus standardized approved instruments for assessing progress. And we have some great recommendations for that as well. There's custom curated batteries of questionnaires you can put together. There's standardized tools that incorporate mental health, measurement tools, substance abuse, all kinds of exciting different ways to measure and track progress. A lack of progress towards goals clearly indicates the need for further assessment and review of the plan. Not all of the goals or objectives are reasonable or attainable by the individual, and that really requires further discussion and revision to the treatment plan. So we're staying strength-based, we're meeting the preferences, and we're really remaining aligned with the individual on what they're trying to achieve throughout their treatment episode and through the course of their life moving forward. So regular review and collaborative revision to a well-documented plan provides mutual clarity and a shared vision for what success looks like. Having a clear understanding between the clinician and the patient is imperative for a mutual and aligned approach to the work that's being done, really maximizing the opportunity of the treatment episode. There is so much value and power and information that comes out of these outcomes questionnaires and batteries and tools in not only how the individual is able to view their own progress and mark measurable benchmarks for progress, but also for the organization to evaluate clinical care and individual providers. You know, accountability is one of our values, and we highly recommend that to be a value at the organizations that we work with as well. Understanding that it can be difficult to get clinical documentation done on time, and there are plenty of reasons why one could see the actual care being delivered being more important than the clinical documentation. But we don't see those as mutually exclusive. We think that they're really tied together as part of a person-centered approach to care. Transfer or discharge needs to be well documented, and as I had mentioned, should start on day one. There's so much opportunity to discuss and talk about the goals and the words of the individual of what they want their life to look like and what they want to be, and then helping them to walk back towards a scope of work for the individual to act on and to execute on, and to celebrate the successes and progress along the way and identify the areas of challenge and opportunity, and have the individual thinking about what the next steps may be that's going to be in their best interest. And there's going to be a different readiness to change with each individual. There are some that might not be ready to talk about discharge or transfer planning on day one, and that is left to the clinical rationale of the provider to determine the appropriateness of which conversations happen when. But at the very least, we really support and suggest opening up a transfer of discharge plan from day one. The transfer of discharge plan needs to be tethered to the treatment plan. So a theme is emerging here as you're listening and hearing me, that all of the documentation around the individual either informs or supports the treatment plan. And that person-centered plan guides the care, treatment, and services. Like I had also mentioned in the past, earlier on today, transfers and discharges can happen at any time. AMAs, payer source cutting off approved days, family members intervening and disrupting the care. These are realities of the situation. It's not always up to us as the provider to decide how long someone attends and at what level that they engage. So remaining in communication and understanding of, if a discharge or a transfer is to occur, what does that look like as it relates to the treatment plan? So that's my presentation around the basics of clinical documentation compliance, hitting on some of the main points of emphasis from a regulatory perspective. And with that, I'm going to kick it over to Alan. Alan has been an amazing resource for Simplifiance. He brings, triple the experience that I have to the table in a unique set of skills. Alan's a licensed clinical social worker. He's also has a history as being an administrator and a COO. And so we're really appreciative to have Alan on our advisory board as a contributor for Simplifiance. We have a ton of respect for his knowledge on the clinical and operational side. And we're really privileged to have him today with us, sharing a little bit more about the reimbursement, utilization review, and payer contracting as it relates to clinical documentation. So thanks for being with us, Alan.
Great. Thank you, Parker, and thank you, Gina. And I appreciate the opportunity to speak to everybody related to documentation from the payer side. I think Parker brought up a lot of good points that we take to that and transition it to the payer side. And it's about detail, and it's about understanding what your customer is looking for and ensuring you give them that. And really tell a story, not only from a clinical side, but from a payer side and what they need. So why don't we just get started? Payer collaboration, I think, is key in any successful business, especially behavioral health business. There's various partnerships, and as behavioral health catches up with the medical piece of healthcare, we are getting more opportunities to contract in various ways. And with that comes synonymous with increased documentation responsibilities and other areas of concern that I think as me as a social worker or as clinicians, we really don't think about. So just real quickly, as you probably all know, there's various payer collaboration opportunities. One is an out-of-network partner, and really that's just synonymous with the fact that you are not contractually obligated to the insurance company. However, with that comes some risk as well as some increased expense on the client side. In-network partnerships are becoming more valuable to businesses as well as, I think, partnerships. You are contractually obligated to do certain things on the payer, as well as you really need to understand the fact that they trust you, and that's why they're contracting with you. So with that, your audit risk becomes a little less, as well as you have a direct line to that payer organization. One of the things that I'm finding I see increasingly more, and I think that as behavioral health care organizations, compliance people, we need to start learning about our value-based partnerships. This is where you kind of have skin in the game, as well as with the payers, where you are sharing the risk, but getting value and added payment based on certain metrics. And one of those metrics is documentation on the clinical side. Every quarter or every 6 months or a year, they will take a look at your medical records, the payer, and documentation is one of many various KPIs or indicators they look at to base if you do get a bonus. Others are claim history, as well as readmissions AMAs, and so on. One opportunity for collaboration that I'm seeing more of also is episodic and capitated partnerships, meaning that you get paid based on a treatment episode. So it kind of rules out and takes out utilization review, as well as any type of ongoing communication. The struggle with that is post-discharge, they can ultimately pull a chart and say, based on this episodic agreement or capitated partnership, you did not meet your standard protocols. And that's why, again, I think documentation that Parker was sharing about is so important. And then we have the self-funded organizations where basically you go to an employer and say, look, we want to be your behavioral health arm. And this is what we do. And of course, you would need to document related to that. And then there's just so many different exposure opportunities and advancements for home care and other areas of collaboration. So I think the takeaway from this is that with collaboration comes responsibility on the provider side. And part of that is the whole documentation piece that Parker shared about. Now, during the contracting process, documentation is key, just like it is with taking care of the clients. Facilities and organizations need to understand what's motivating that payer, understand what the payer's pain points are and what they're getting from other organizations, what differentiates you from that organization, key talking points, why would they want to contract with you, and with that, your acceptable rates. So again, as you see, there's this theme of documentation on both sides, on both the clinical side as well as the business contracting side. I think it's important that first impressions are vital. So when they ask you for a request for certain information, you get them that right away, as well as you ensure that what they're getting is what they're asking. All that is going to, I think, make it more advantageous for you to ask for better rates, as well as better opportunities on the utilization review side, capitated rates, as well as maybe even developing some relationships where you do not need to do utilization review. How you present is diagnostic of how your rates are going to be. And I really believe that, as well as how your documentation is clinically, and I've seen over and over again the last 30 years, is diagnostic of how the payers are going to want to partner with you, refer to you, and ultimately prevent any SIU, which is Special Investigation Unit audits, which ultimately you have to unfortunately give some blood to get out of those. So documentation, payer and MCOs, managed care organizations, during the contracting process, what are we looking for? We need to complete the application fully with no errors, no typos, ensuring that the quicker, it's like a clean claim or a clean medical record. You need to send a clean application to prevent any additional time it may take to go through this process. Secondly, the documentation must be most current. I've gotten applications turned back from me because the W-9 is a 2021 W-9, not a 2022, as well as certain schedules are based on not level of care, and they are based totally on the organization as a whole. Credentialing, the majority of the payers do require a board-certified psychiatrist to lead the treatment team, as well as a medical director. These things are just unfortunately becoming more prevalent as we treat co-occurring disorders. And not only that, they need to have some high-level individual ensuring that psychiatric care is being met. Also, from a facility standpoint, I think it's helpful because it drives medical necessity. And understand that you're going to need your MPI numbers, as well as the CAQH portal, which is the portal that permits insurance companies and credentialing organizations to go in. And basically, it's like electronic resume that your therapist should all get a CAQH number and fill out the information included in that. Upon doing that, I think, there's a decision to be made. Does an organization go out of network or in network? That you need to understand your historical out of network payments, the documentation related to getting those out of network payments, as well as the rates in network. We have found working with organizations in helping them contract in network, it allows for more partnerships, more scalability, and more credibility, especially if you're a community-based facility. And then ultimately with clinical documentation, you really need to really look at your audits based on payers. Certain payers are going to have certain different requirements associated with their clinical documentation and also the language used in that clinical documentation. So the provider documentation responsibilities, as I shared with you, whether you're in network or out of network, documentation is key, but even more so on the in-network side, you're contractually obligated. So really what organizations need to be responsible for and understand they are is that the payer partnership documentation requirements. Unfortunately, a lot of organizations, especially on the out-of-network space, will get a letter saying send some charts in. They will review 4 or 5 charts, extrapolate that if 4 or 5 charts do not have a psych eval at a certain time or a discharge summary at a certain date or completed treatment plans, they would assume that probably 80% of your charts are like that. So they will extrapolate 80% of the revenue that they paid you, the reimbursement they paid you, and request that money back. ASAM guidelines are the key guidelines right now. MCG, the Milliman is also some guidelines. I do business in North Carolina, and Milliman is a big player there. Payers are getting away from their own criteria due to some litigation and losing lawsuits. There was a big one with Optum that they followed their own guidelines instead of using standard industry acceptable evidence-based guidelines. Organizations should always have a resource kind of center. I call it a resource station where all your forms and portals are at a place so people can access it. Understand that what your pre-authorization requirements are, continued care, discharge and appeal processes are. You need to become an expert in that process. One of the things we talk about a lot is having an insurance champion and a documentation champion. That means within the organization, there's an individual you can go to that will know everything about everything related to insurance, clinical documentation. And many times I find that these are therapists or clinicians who we train up and understand the payer side. Look, I mean, we all know that the longer somebody's in treatment, the better opportunities they have and better prognosis they have. With that, the only way they're going to do that is with good documentation. And document with the understanding that the medical record will be reviewed. Many times as a young therapist, I didn't realize that. And unfortunately, I would get called about something. Payer auditors are looking at your stuff, external providers, external accreditation bodies, and then ultimately the legal system. As we treat sicker people, unfortunately, increased critical incidents are occurring. And with that, your medical record kind of becomes your kind of weapon or your enemy associated with dealing and processing these type of issues and ultimately resolving them. So what's the provider documentation responsibility? As I shared with you, it's really important that you have a champion. Everybody should have a champion in an organization. Some organizations that are large and have significant resources and multi-site have a department that's all they do. Others are smaller. Some the clinical director is that champion, a PI director. It really depends on really where you're looking and what you need. But I really think it's important that that champion is empowered to become an expert and a thought leader and a subject matter expert for your organization. I think on the revenue cycle management side, it's vital that there's constant communication between your clinical people and also your leadership, as well as your utilization review, and of course, revenue cycle management, the billing collection people. I think getting a barometer and understanding certain key indicators will ensure you get reimbursement, as well as you can address any authorization or other areas that really are important to getting reimbursed. And then establish, of course, quarterly meeting with payer partners. I have found that to be vital, that the organizations I do work for, I really believe in outcomes, and we provide outcome reports based on the payer. So say we use an outcome system and we have 50 Blue Cross, we have 500 clients, but there's only 50 Blue Cross. We will take out those 50 Blue Cross people and do the outcomes just specific to that payer. They like that. They have ammunition to show that care is working or not, as well as the contracting. So really the outcome processes are based on number of external outcome providers. It meets accreditation standards. And what I mean by that is, as an organization, you need to find an outcome system. That could be internal, that could be external. But if you're looking for an external, I really think you need to really do a deep dive like Parker shared. They need to meet accreditation standards, meet outreach and marketing efforts. We have found that your outcomes are incredible in marketing, incredible for websites. Many families do call, what are your outcomes? And these aren't only outcomes post-discharge. These are outcomes for patients who are admitted, and you identify their pathology by standardized tools, and then at discharge what their pathology is. So you could show a movement that people have gotten better. And also it supports your collateral information, as well as speaking opportunities and demonstrating success. And then finally, what I have found being involved in the merger, acquisition, and due diligence process, outcomes is a box you really need to check. For people coming to look for you, to purchase you as you acquire facilities, I think there's two things. One, organizations want to know about outcomes. As two, as I think it also shows significant credibility for organizations to do outcomes, especially in this space. So utilization review. So really that's the gist of the outcome. The contracting piece and the documentation piece. With that said, I just want to talk briefly about the utilization review process. Again, utilization review is an extension of the contracting process, meaning that part of that contract means that you are going to be requesting authorization. I think it's important the community organization, if you're multi-site or if you're one site, really has a good vocabulary of what the payer is looking for. Clinicians as well as administrators need to understand language specific to payer, because it is different at times and what they're looking for. And also it really serves as an internal compliance tool associated with, for example, there's many companies with no certs, right? No authorization. Well, we have found that you do your own internal authorization and yet get your days certified internally by your UR company, or your internal UR people, that really permits you kind of validation that you're providing care at the right level. Quality process audits. Internal audits should be conducted monthly. I really believe in auditing is key. I know companies have had significant organization audits from payers, and ultimately what they'll do is they'll call it a high-risk payer, and they'll hire somebody just to review 80% or whatever amount of those charts. Remember, for the majority of providers, Blue Cross Blue Shield or Anthem are about 75% of their payer mix. So many times that's significant revenue, 75% of your revenue, it's worth hiring somebody just to review those charts. And then also, of course, discourage the blame game. Many times I'll sit in meetings, your team will blame the clinical team, and then the clinical team will blame the UR team. And again, it's all about collaboration. And then also the documentation that more so that Parker brought up is know your hot spots, know your vocabulary that promotes medical necessity. The things that I have found in medical necessity that are really drive good documentation is relationships, family, mental health is key, as well as the environment. It's a story and it's not event-oriented documentation. And then also what we call use power quotes. Client remains at the risk for, limited progress in, current systems and symptoms include. So really what we've talked about here is two things, right? We've talked about contracting, the documentation related to that, payer partnerships, and then where we need to go with utilization review to ensure that we're meeting our obligations, as well as the clinical documentations there. So really the ultimate mission of payer and organization partnerships are we meet our contractual obligations, partnership is to ultimately benefit the member receiving the care, facilities meet the medical necessity and documentation obligations, payers meet their timely reimbursement. And that's the whole thing, we need to really hold our payers accountable that reimbursement authorization and the systems are in place with not to limit our obstacles to treat the care. Regular communication with the payers is key, and understanding of documentation requirements from an organizational standpoint so you can get reimbursed. So really that's kind of the gist of it, Parker, related to Gina, related to what I think are important parts of both the contracting side as well as the clinical side and that documentation. Thank you.
Thank you, Alan. Thank you, Parker. We do have time for questions. If anyone would like to throw a question in the chat, we'd be happy to answer questions for you. And if I can ask you, Alan, to go to the next slide.
Sure.
For those of you that are interested in learning more about Simplifiance or Behavioral Healthcare Advisors, here's our contact information. Feel free to reach out to us at any time. There is one question that did surface, and this is a question to Parker. Specifically, it was around, is it required to do a biopsychosocial before a client admits, or can you do a biopsychosocial after the client admits, and how much time do they need to have?
Yeah, well, that's a great question. So a biopsychosocial is the extensive assessment that captures all the biological, psychological, and social pieces of information relevant to the individual. And it does not need to be completed prior to admission. And the pre-screen assessment really serves as an abbreviated version of the biopsychosocial, which does need to be completed prior to admission to determine the appropriateness and if they meet the criteria for admission. And then a biopsychosocial, the required timeline for completion varies state by state. But our recommendation is to have that done within the first 48 hours. That will vary based on the patient's mental status. If they're in withdrawal management level of care, that's going to vary as well, because you want to collect, accurate information that's understandable to the individual and the provider. So typically the regulatory authorities, the states, for example, require somewhere between 3 and 7 days. But our recommendation for best practices is to complete the BPS within the first 48 hours of an admission. And to directly answer your question, no, it does not need to be completed prior to the admission.
Thank you. It doesn't appear that we have any more questions at this time. Again, I'd like to thank Parker and Alan for their time today. And for those of you that are interested in accessing this recording, you can check us out at simplifiance.com. It will be uploaded this afternoon. And then, of course, there will be certificates that will be sent out to you by Friday. Please join us on February 15th when we will be featuring Braden Smith, Executive Vice President for Simplifiance, who will be speaking about HIPAA and security as it relates to compliance. Thank you all for attending.